Thanks, Bruce. Let me just take a moment of welcome. It's just great to have all of you here today. One of the things we've done, I came here, it's been 4 years now, from Canada, and one of the things we've done is try and expand this program so it's not just for the primary care physician, it's for allied health professionals as well. And I think the term allied health professionals is a nice one because we are all allies in the fight against visual problems in children, and each of us plays an important role in working together to make kids who have visual problems get what they need. So this is a day that's designed hopefully to cross all of our allies and make kids see better in Philadelphia. Wills has a big commitment to the care of the community of children in Philadelphia. On April 14th, we have our Give Kids Sight Day, a day when we open up our, I think it's April 13th, Saturday, whichever is the Saturday. We open up our doors to any child in Philadelphia who wants free health care, free eye care for that day. Last year we saw 1,200 children, and those children get free glasses if they need them. We are trying to reach out to those kids who are uninsured or underinsured. We are always looking for volunteers for anyone who learned something today that they want to do that day. Everyone in this room is eligible to volunteer. We need screeners and everything. It's a fabulous day supported in our collaboration with Public Citizens for Children and Youth, PCCY in Philadelphia, the Philadelphia Eagles Youth Partnership, who are here today, and thank you for that, who helped to provide the free glasses, and numerous partners throughout the city, the school district, and others. So it's a great day, and just one of the things we're trying to do. We had hoped today that we would have Wheels on Wheels for you, which is our mobile eye unit that now goes out to schools and does screening and sees kids who have failed their nurse screens in school. But unfortunately, it broke down, so it was unable to be here. It's under repair. I'm going to talk to you about vision screening. We have an exciting day planned for you with some hands-on things. You'll hear more about that as things unfold. So vision screening is really the perfect place to start the day because that's how kids get in the system, right? They get their vision screened, and if they fail, they wind up getting referred. So there's some cardinal rules of testing vision. And by the way, there are handouts, so all of my slides are in there, and I think most of the speakers have their slides in there. Always test both eyes. Kids come in, he's in the schoolyard, he's punched in the eye, he's got a big swollen eye, and you measure the vision, and it's lousy. Well, if you measure the vision in the other eye, you might find the other eye is lousy too because he just needs glasses, and the lousy vision in the punched eye has nothing to do with being punched in the eye. So always test both eyes one at a time. We'll talk a little bit more about that. We don't care what vision is with glasses off. That's like, you wouldn't want me to operate on your kid's cataract without my contact lenses in. It wouldn't be a very good outcome. We don't ask people in a wheelchair how fast they can go without their wheelchair. Measure vision with glasses on, and we'll talk about what you can do when a kid forgets their glasses, and that comes to the pinhole test. And remember, always test vision. So when should you test vision? Well, the American Academy of Pediatrics says every well-child visit you should check vision in some form, and certainly when evaluating any eye problem. There was a study once that calculated that if pediatricians did every single thing that was recommended by the American Academy of Pediatrics, that a well-child visit would take 8 hours. So it's hard to do. And by the way, I'm a pediatrician as well as an ophthalmologist, so I've been in the trenches in a pediatric practice. I know what it's like. And what I will tell you is that the vision part is really just a second or two, and we can show you how to do that. Why bother testing vision? Obviously, it's to detect early things like amblyopia, which you're going to hear about from Dr. Ali, a new member of our staff, and also treatable disorders like cataract, which is kind of my bag. What do you do in kids who can't read a chart yet? It's very simple. You cover one eye. It takes 2 seconds. Cover one eye. You should put my hand on their head like this and just put my thumb down with a little toy or even my face. The kids, as early as a month or two, who have one eye that sees worse than the other will get upset when you cover their good eye. And that getting upset may be moving their head around, maybe trying to look around. As they get a little bit older, batting your hand away. It may be going to sleep, closing their eyes. It may be crying. But what you're looking for is a change in behavior when you cover one eye. If there's a change in behavior to the negative side, then you are covering their good eye and they're getting upset. Levin's law states that most children have two eyes. Fairly reliable, fairly reliable. The corollary is that kids cheat. And one of the big problems we see is kids that never got picked up on their screens in pediatricians' offices and schools. And that's simply because if you don't cover them right, they will cheat. And I would challenge all of you right now to take one hand, put it over your eye, everybody do this, and look at me. And no matter how hard you try and squeeze your fingers, you can find a crack to see me, right? And that crack actually improves your vision, as we're going to see. It pinholes your vision. So not only do they cheat, and they don't do this on purpose. This is the natural way their brain is wired. It's wired in a fashion that drives them to use their better eye. And as Dr. Ali is going to tell us, that's the basis for amblyopia. Now, we prefer to cover with a 2-inch piece of paper tape, just slap it on, but you have to be careful because they can cheat even with that, okay? And kids do this all the time. So how can you prevent this? And the way to prevent this is you should keep your eye on the child. When you're testing vision in your office or in the school, or wherever you are, stand next to the chart and look back at the child. Make sure that you're testing the eye you think you're testing, especially in school and busyness where kids are crazy and things like that. Really important to make sure that you know what eye you're testing. 2-inch paper tape is pretty cheap, too. You can get a roll of that and that'll last forever. So that's a good cheap way. You also have to make sure you're using the correct chart. Now, I usually ask a mom or dad, I say, can your kid read? If they say yes, he's reading War and Peace, then I'm pretty comfortable with letters. Anything less than that, they say any kind of hesitation, I'm pretty good. I won't use the Snellen chart. The Snellen chart is, of course, this chart here, which is the letter chart, but we have other options for kids where you're unsure. We don't recommend the tumbling E chart. Unfortunately, that requires handedness. Handedness in children doesn't develop to 4 to 6 years of age, and by then most of those kids can do the other charts. It's a little hard and confusing to kind of go which way. If you're stuck with that, we often say, what's the table? Here's a table with legs. What way are the legs pointing? Picture charts are fine as well. They don't go below 2030. They're not accurate below 2030 or better than 2030. And if you're using the colored chart, be careful not to use the yellow pictures. Contrast in fluorescent lighting is poor, and therefore it's harder for the children to see the yellow pictures, so we recommend just ignoring those. One of the best kind of in-betweens are matching games. And there's a matching game called HOTV. This is one called Sheridan Gardner. Very inexpensive. You can purchase it on the internet, where the child has a card where they point to what you're holding at the end of the hall. So here's an O, and you'll just trust me, there's an O under her finger that she's pointing to. That matching is especially for kids when they're shy and not in the mood to talk, to get an answer and a reply. It's very, very easy and very well tolerated. And also, don't be boring. Don't start at the top and go all the way down. Kids should be 20/20. When I see a well child in my office, the first thing I do is show them 2 letters on the 20/20 line. If they can get those 2 letters, they're 20/20. I don't have to read the whole line across. And we tolerate little errors. You know, an O instead of a D is okay with me. An F for a P is okay with me. But if they get those 2 letters, so I literally, they're in my chair, I show them 2 letters, they say E-O, next I. That's it. That's how long it takes. Now, if they don't get that, I'll back off a couple lines. Maybe go up to D-E here. It's a 20/40 line. If they get that, then I go forward again. Sometimes they just need a little bit of kind of head start, a little running room to get going. So in general, start at the best acuity and work with it. Don't start up here. They'll be picking their nose by the time you get down here. Right? And 2 letters per line is fine. They didn't guess 2 letters, right? It's 1 out of 26 times 1 out of 26. The odds of doing that are pretty low. We want you to write something down. It's really important. I can't tell you how many times I see a kid, for instance, with a cataract, and I have to decide, is it worth taking this cataract out? Well, that depends on whether they had better vision before. And I have to go back to the pediatrician records, and time again, there's nothing in the record about what they saw. What does it mean to see 2200? It means that the patient has to stand at 20 feet, okay, that's the top line, to see what a normal person can see at 200 feet, the bottom line. So 20/40, my patient has to stand at 20 feet to see what a normal person can see at 40 feet. Write something down. A lot of people say, well, we don't have a 20-foot lane. Guess what? We don't have a 20-foot testing lane either. So if it's 10 feet, what do? 10 feet, most people have 10 feet, right, unless you're working in a closet. And those 10 feet, all you do is you double the value of the line. So the 20/20 line becomes 20/40. The 20/40 line becomes 20/80. There are 10-foot lane charts that you can buy, but taking it that way, you can use the really common chart that you may have around and use a 10-foot lane. When you write something down, we have metric as well. Being Canadian, I have to put that in. But at the very least, write down that, can fix and follow, can see my hands, can count fingers. Something is better than nothing, not just a pass-fail. What do you do if the kid fails the exam? Well, the first thing you should do is look at their near vision. And if you don't have a near vision card, give them a normal book. Just, if they can read up close and they're terrible at distance, they're nearsighted. 9 out of 10 times they're just nearsighted. They need glasses to get better. But the real test, the best test, is to use a pinhole. Now, you can buy a fancy pinhole as shown here, or you can take an 18-gauge needle or a pencil and poke some holes in the patient's chart and have them hold it up in front of their eye and look at the end of the hole. And if their vision improves, and I would say through a handmade pinhole, I'd expect it 20/30. If their vision gets better, then you know for sure that the only thing wrong with that patient is that they need glasses. So after a punch in the eye, a fall on the playground, something like that, 2400 vision, you give them a pinhole, they get down to 20/30, you know that the injury didn't cause the problem. They just need glasses. Any improvement with a pinhole can only be due to the fact that the kid needs glasses. Great trick. Also great to use when the kid forgot their glasses. Don't even bother measuring their vision without their glasses. Put up the pinhole, let them read, and record that as their best corrected vision. When do you refer? So these are the American Academy guidelines. If a child is before grade 1, anything less than 20/30, so 20/40 or worse, or in that preference test, anything that makes you think that one eye may be seen better than the other. If they're grade 1 or higher, they should be able to see at least 20/25 in each eye. And if they're reading a chart, any difference of 2 or more lines between the 2 eyes buys you a consultation. Now, a couple things on consultation. What's really important here is that the kid gets seen. For example, in the Philadelphia School District, 14,000 children every year fail their school screen and never see an eye doctor. Horrendous figure. Thanks to the Philadelphia Eagles, about 3,500 additional kids do get seen. Thanks to Wheels on Wheels, and a few more get seen. But even those kids who get seen by the Eagles only 50% who get referred to the eye doctor from the optometrist on the van actually get seen. Making the connect is hard. We have a research protocol here with a social worker that we hire that's specifically deemed to try and get these kids in. But you need to see that the kids connect. Doing a school screen and as a pediatrician in your office and referring a kid and they never connect, and you see them a year later for a well child and they never got there, obviously isn't very helpful. So we need to really try and get these kids in to be seen. So a referral is nice, but it's only good if it gets completed. What if it's not glasses? Well, if you know that the kid didn't get better with a pinhole, well, then you're in the right place, because that's what the rest of this meeting is about. All the other things which would make vision bad that aren't going to get better with a pinhole, and what do you do about them. Now, when in doubt, never hesitate to call. There's a lot of things, a lot of times when you're kind of, what do I do here? I don't know. And I put in the handout and I put up here, you can call my cell. You can email me, although if you want less than 24 hours, I'd suggest the cell phone. This is the clinic number. We have a 24/7, 365 day of the year emergency room for eye problems at Wills. It's actually located in the building across the street. It is the only such ER just for eye problems in the country. We are happy to help anytime. We will see any child regardless of their ability to pay, regardless of their insurance. We can figure out how to see just about anybody. And that's what we're here for. We're happy to see these children. So if you've got a kid who you don't think is going to get in, an immigrant who doesn't have insurance, some reason there's an obstacle, let me know. If you think there's something urgent, whether it's an eye injury, they can always go to Will's ER, but you can call me. You can call our clinic and try and get the patient. I know sometimes our phones don't answer right away. We got a large volume of calls. We're working on that. We apologize if you have trouble, but the bottom line is we're available. We specialize here in many kind of tertiary things. I do pediatric cataract, glaucoma, and genetic eye disease in children and adults. But even the kids who just need to see an eye doctor need to be seen, and we're here to try and help you. So feel free to reach out. I want to thank all of you once again. I want to thank our speakers who come today, unpaid on a Saturday, to give their talks. I want to thank Bill Romano in the back, who's one of our excellent AV guys, Vaughn and Ela, who you met out front, who are our CME staff. A special thanks to Dr. Ed Yeager. It's very rare that you can be in a room where you can see the portrait of a man and the man himself in the back. Dr. Ed Yeager is a very, very, very famous ophthalmologist, not a pediatric ophthalmologist, who's been a leader in medical student education, ophthalmic education, and he's helping us with our demonstrations today to get you to learn how to use the direct ophthalmoscope. So many thanks to everyone, and especially thanks to you. Take care.